Good afternoon, everyone. Good afternoon and welcome to today's webinar on the systematic review, approaches to promote hand washing and sanitation behavior change in low and middle income countries. Just quickly introducing myself, I'm Chaitali Chattopadhyay and I work with WSSCC. I manage the monitoring and evaluation portfolio for the council. I have with me here Valerie Valera. She is the evaluation support officer and has done an incredible job so far on this webinar. Before we get started, I just want to quickly take you all through some of the housekeeping rules so that we have a smooth running of the webinar. We have about 200 participants who had signed up for the webinar, so they will be joining in as we speak. So we do have a good turnaround, I guess. This webinar for learning purpose is being recorded, and we will be tweeting during the webinar. You all are requested to mute your microphone so that we all can have a clarity during the discussion and the webinar. With regard to the questions, we have designed the webinar in such a way that we will be pausing after every section, and there will be an opportunity to ask questions. Please note that when you have an access to the chat box, which is on the left panel of the screen. So when you want to ask a question, just type your name and type the question, and then I will call on you. And at that point in time, you will have to unmute so that we can hear you out, and just introduce yourself, your organization, and the question. We have limited time, so I'm sure there'll be a lot of questions from your end, and we will not be able to address all the questions. However, don't worry too much about it. What we have decided is that you have an opportunity to send your questions to Valerie, who has been in touch with all of you to set up the webinar. And you will have to send the questions by close of business today. We will try and address some of the recurring questions, 10 to 15 recurring questions in a couple of weeks' time, and we will email it to all of you so that we have a good discussion going. Now, with that, let's get started with the webinar. And let me quickly introduce the speaker of the day, and that's Dr. Emmy Debak, and she is the lead researcher of the systematic review, and she's actually a manager and lead researcher at the Center for Evidence-Based Practice in the Belgian Red Cross Flanders. So welcome all of you, and welcome Emmy. Before I give the floor to Emmy, I would just like to take you all through a few slides that gives a snapshot of the program, Evidence for Sanitation and Hygiene. And the study we are presenting today, the systematic review, is a part of that program. Emmy, I'm going to request you to please take over the slides. So the evidence program for sanitation and hygiene was commissioned in 2014 in partnership with CIE, the International Initiative for Impact Evaluation. And the vision behind this program was to make sure that we fill some of the existing sector gaps through robust evidence that could help the decision makers to improve their policy and program impact. So, like I mentioned, that this program is in partnership with CIE and WSSCC. As some of you already know, WSSCC, that is the global membership organization, and has the spirit of collaboration pretty much at the center stage of its work. It does a lot of policy advocacy work, and also hosts a global sanitation fund at the council. CIE, on the other hand, is mandated to generate high quality evidence to deliver better policies and programs in order to improve the lives. They offer technical expertise with regard to evidence generation. So these are the four facets of work that comes under the program Evidence on Sanitation and Hygiene. We have commissioned 2 impact evaluations, 2 systematic reviews, 1 advocacy evaluation methodology, and a corporate evaluation, which was the council's midterm evaluation. This is just a snapshot of the partnership that has resulted as a part of this program, even though the initial partnership was with CIE, but as a result of it, as you all can say, that we have gotten into a lot of interesting partnerships with different universities and research centers. Here you can access more about the EPSH program. The first link is to the EPSH brochure, and the second link is to the YouTube video, which presents a very interesting story behind commissioning this piece of work or this program. With that, I'm going to pass it over to you, Emmy, to present the substantive aspect of the systematic review. So over to you.
Thank you for the introduction, Chaitali. Hello, everyone. Thanks for joining this webinar. My name is Emmy de Buc. I'm the head of the Center for Evidence-Based Practice, and this is a group from the Belgian Red Cross, where we support all the activities of the Belgian Red Cross with evidence-based practice. We do this for the blood service and for the humanitarian services. And, this project on hand washing and sanitation promotion programs, change is one of the important aspects of our work. So this project was a collaboration between our center and the Center for Evidence-Based Healthcare from the Stellenbosch University. A lot of other team members were involved, like experts from the University of Leuven in Belgium, and Professor Moseler from IAWAC, and several other team members who had a role as a statistician or as an information specialist were also involved in this project. So the aim of the project was to identify evidence on hand washing and sanitation behavior change approaches, and this is because early wash interventions that merely focused on hardware components such as providing infrastructure and water supply and water quality interventions, these type of early wash interventions, they seem to have not enough impact over a long time, so on a longer term. So that's why we were interested in these newer approaches to promote wash behavior, which we call the software approaches. And some examples are community-based participatory approaches or social marketing approaches. I will come back to that in more detail in the next slides, but this is the start of our systematic review. It was currently not clear which of these approaches were the most effective. We're also interested in factors that influenced the implementation of these approaches. That's why we started the development of a systematic review, and this was done with funding from the WSSCC and 3IE. So very short, what is a systematic review? It is an overview of existing research studies which are identified and selected in a very rigorous and transparent way, and then further analyzed, taking into account the quality of the studies, and leading to a synthesized conclusion on the best available evidence. This way of working tries to minimize bias and is a high quality standard of working. So this is the outline for the webinar. Essentially, our project had three big steps or three big phases. And phase one was a preparatory phase in which we developed an evidence gap map. And we did that based on an overview of existing systematic reviews. We first checked if other systematic reviews or identified evidence on this theme before we start our own review. So I will come back to that in more detail in the next slides. But then phase two was the actual systematic review. So there we really looked for existing primary studies. I will discuss the results of the review in detail, of course. The third step was translating our information into practical statements, and we try to develop a communication and dissemination plan. So we will explain a little bit more what our conclusions mean for practice. Throughout the whole project, we worked with a theory of change, and I will explain in more detail what it is and how it looks like. Helped us as a framework, as a central thread throughout the whole project. So it was a really helpful tool to structure and arrange the results of our systematic review. So let's first start with the evidence gap map. So the aim of our systematic review was to explore which promotional approaches are effective to change sanitation and hygiene behavior, which implementing factors affect the success or failure of such an intervention. Before we started the systematic review, as I said, we checked for existing systematic reviews on this theme, and this led to an evidence gap map. So I will present you the evidence gap map here. So the evidence gap map exists of several components. At the left part of the map, you see the intervention of interest, and the intervention actually exists of two different components. First of all, the wash component, and there we have water supply, quality, sanitation, or hygiene. Then, of course, the second component of the intervention, promotional approach. I will now not provide more details on the promotional approaches that are mentioned here. We'll do that in more detail a bit later, but this is just to give you an idea of the existing reviews we identified. The second part of the evidence gap map, right side, is showing you the outcomes of interest. We actually had two research questions looking for effectiveness of promotional approaches. The other one, question 2 at the right-hand side, was looking for factors influencing implementation. Again, I will give you more details on the different outcomes of interest in a minute when I'll discuss the theory of change in detail. Every time you see a reference mentioned on the gap map, this means that this is an existing review on this specific topic. So this gave us an idea about the gaps there were in evidence. You see that there was not a lot of evidence available on sanitation, promotional approaches on sanitation, and on hygiene. And for the outcomes, there was no review that looked for outcomes on the longer term, we call sustainability. So these were very important aspects for our own review. And for us, this resulted in a very focused formulation of the research questions for our own systematic review. So the take-home message of this preparatory phase for the review is that an evidence gap map based on existing systematic reviews was developed to know the gaps in evidence, of course, and to be able to formulate our research questions for our own systematic review. And the result was that in our own review, we focused on hand washing and sanitation. So this is a short introduction and some explanation on the preparatory phase of the review. So before we go to the actual systematic review, I will explain you our theory of change, because we used it as a central thread throughout the project. So first of all, what is a theory of change? A theory of change is a theory of how and why an initiative works. It is a framework in which you try to map the change that you would like to achieve, where you try to explain all the links in the framework. So some more information on the next slide. It is a way of modeling how change will happen in a program or intervention. It contains hypothesized causal links. It contains different types of outcomes, the short, the intermediate, and the longer-term outcomes. And it also contains some positive or negative mediators or moderators of every step in the theory of change. Our theory of change was developed based on existing models of wash behavior change. We also used existing frameworks of program implementation and frameworks on equity. And of course, we used the information of the existing systematic reviews we identified, and we worked together with a group of stakeholders that also provided a lot of input. And I will come back on this stakeholder input aspect in a couple of minutes. So I'll present you our theory of change, and I will zoom in on the different boxes, different aspects of the TOC, because this will help you to understand the structure of our systematic review and to understand the different results we obtained. It's a basic structure. On the left hand, you see the promotional approaches or the interventions. On the right hand, you see the outputs and the outcomes. You see four yellow boxes, and I will explain every category of promotional approaches in more detail. So the first one is the community-based approaches. I think it's important to already mention here that these four categories were created after we developed our systematic review, because it was very difficult. In a lot of studies, a lot of promotional approaches were described and there was a lot of variability. So based on the main component of the promotional approach, we created these four groups. But I will explain on each group. I will provide you a definition and some examples. Community-based approaches at first is an approach where community members are invited and there is shared decision-making. It's an approach that works with the whole community, and typically community meetings which trigger behavior change are conducted. So I listed some examples here. The CLTS approach is an example of a community-based approach. Also the participatory rural appraisal, the FAST approach, the SARAR approach, a community reunion, community health clubs, for example, are all examples of community-based approaches. The next group of promotional approaches were the social marketing approaches. So a social marketing approach combines enterprise approaches with demand stimulation. It assumes that people both want and are able to change their behavior. It is an approach that focuses on what they call the 4 Ps. And the 4 Ps stand for product, price, place, and promotion. It's a task of an organization implementing such an approach to determine the needs, wants, and interests of targets, and to deliver these satisfactions more effectively and efficiently than the competitors. So it's a competitor-based way of working. Listed some examples here. So first of all, there can be marketing of a single intervention, such as the SANIA approach or the public-private partnership for hand washing with soap approach. Or it can be marketing of sanitation goods and services, which is a bit broader, and I provided some examples, such as Sanimart, Sanmark, or the total sanitation and sanitation marketing. We have the sanitation and hygiene messaging category of promotional approaches. This is very important to frame it very well. It is actually an educational approach, but it is a very directive educational approach, where there is mainly one-way communication. It's designed to help individuals and communities improve their health, increasing their knowledge and or skills, but in a one-way communication style. The approach aims to educate health-related aspects of hand washing and sanitation. Examples are school-based approaches, so, a lecture style of teaching in schools. This type of approaches can also take place outside schools. Then we have the elements of psychosocial theory. It is in a separate box called assessment here. I will clarify this further in the webinar. But I'll first provide you with a definition of this category of approaches. Behavioral factors are derived from theories, then addressed with specific interventions, behavior change interventions. Knowledge, feelings, social pressure are examples of behavioral factors like this. These elements of psychosocial theory are in first instance derived in smaller scale studies. They should be incorporated in a larger promotional approach, able to implement at scale. And that's why it is also shown as an assessment phase that comes before the other boxes. Examples of elements of psychosocial theory used in the FOAM approach, the IBM WASH framework, ABCDE framework, the EVO-ECO approach, RANAS model. So then we will focus on the outcomes of interest. We have short-term outcomes, intermediate outcomes, and longer-term outcomes. First of all, the short-term outcomes. These are also called the behavioral factors, and these are based on the RANAS model. So we have 5 different boxes there: knowledge, skills, attitude, and self-regulation. The intermediate outcomes, the actual behavior change outcomes, also based on the RANAS model. And, these are divided in 3 aspects: intention, use, and habit. Intention means having the intention to practice hand washing and sanitation interventions. Use is the actual performing the behavior, actual showing of the behavior. And the different outcomes of interest were hand washing, use, safe feces disposal practices, and purification practices. For all these outcomes, it was important to make the distinction between uptake, adherence, and longer-term use. I will come back on the specific definition of these 3 aspects. We checked outcomes on the shorter term and on a longer term. And then we also included habit to practice hand washing and sanitation interventions, because this is based on the RANAS model that we used as a basis for our theory of change. The longer term outcomes are mortality and morbidity, and more in detail we were interested in diarrhea, acute respiratory illness, gastrointestinal illness. These are the outcomes in our theory of change. Then one step before that, we have the outputs. And the outputs are also called the process evaluation factors. And process evaluation determines whether a program has been implemented as intended. So process evaluation factors are actually measures of program implementation. And some of these factors are listed in the blue box there. An example is the DOS of a program, which refers to the content, frequency, duration, and coverage of a program. The next boxes are all boxes containing factors influencing implementation. And these are grouped in subgroups. All the information in these subgroups is based on qualitative research, and I will also explain in more detail once I provide some more information on the qualitative studies we included in our review. So what was very important is that we developed this theory of change together with a group of stakeholders. So we held a stakeholder meeting with our team members and with additional stakeholders, several development practitioners from different Red Cross national societies. And from the very beginning, we also included policymakers, topic experts, donors. This first stakeholder meeting was with a smaller group. And together with these stakeholders, we worked on the theory of change. We also defined the definitions that were used in our project, the research questions, the selection criteria we used. The stakeholders helped us to provide sources and relevant websites for screening of relevant information for the review, and already discussed from the beginning good opportunities to disseminate the results of our review. So the conclusion of this section is that a theory of change was developed and was used throughout the review process, and working with stakeholders allowed us to develop a theory of change that was really relevant for practice. And it helped us to already include the practice perspective in our review from the very beginning of the review. We'll again pause for a couple of minutes to allow you to ask some questions on the development of the theory of change.
Thank you, Emmy. I am aware that Mr. Jean-Claude already has typed a question. His question was referring to the difference between open defecation and fixed place defecation. I'm going to request John, if you could spell out your question to Emmy. Maybe he's disconnected. He's having connectivity problem. Never mind. Can I request the other participants to ask their questions if they have any?
Maybe I can already try to answer the question, or should I contact John afterwards, Chaitali?
No, just try and respond to the question, and then we can revisit it afterwards also.
Okay. So if I see it well from the chat box, John asked the question if there was a difference between open defecation or defecation in the open, defecation at the fixed point. So I think always at the same fixed identified place. So this is very difficult with studies that you identify and include in a review, because you only have the information that is provided in the study, and sometimes it's not really well described or not really clear what definitions the authors of the study used for their own study. So in almost all cases, just use the terminology open defecation without any further explanation on what they specifically meant with that. So because of that, we also use this term open defecation, which is probably a combination, defecation in the open and defecation in the open on a fixed point. But we don't have much detail on that, and we couldn't make any distinction or any subgroups there. So it's probably a combination of all types of open defecation.
Yeah.
Any other questions?
Thanks, Emmy. Yeah, any other questions? Emmy, we have a question from our staff here. We have got a couple of colleagues sitting here.
Hi.
Yes.
Caroline van der Voorde. Just a question about the change. You said it was based or open debate of Rana's model. Did you look at any other theories to check of any behavior?
Sorry, I can't hear you, and there is somebody disturbing the line, I think.
We've muted them. So Caroline, go ahead.
Yeah, sorry. I was just curious to know if you had, obviously you have used the Rana theory of change that you made, but did you have a look at any of the other behavioral change models and whether their theories of change, vary very much, or was it the only theory of change you found?
So your question is about the Rana's model that we used as a basis for the theory of change, and if we also checked for other existing behavior change models, eh?
Yes. Yeah, and whether that an influence for theory of change.
So during our overview of systematic reviews, so during the preparatory phase for this project, we also identified a systematic review of behavior change models in the WASH sector, published by Dreibelbis and colleagues. And we used this review as a basis for our own theory of change. And in this review, the Rana's model was actually the only one targeted, the only model that was across all aspects of WASH, sanitation, and hand washing at the same time. So that is why we chose this model from the systematic review. But of course, we checked other models, and if there were factors that were relevant as well, we just added these factors to the theory of change. So the ANAS model was used as a basis framework, but the IBM WASH model, for example, which was then developed by the group of Dreibel based on their own systematic review, also provided some elements for our theory of change. And we checked other behavior change models as well. And we also had a behavior change expert in our group, and several WASH experts as well. So a lot of information was also provided by the different stakeholders in our group during our stakeholder meeting.
Thank you, Emmy. Any more questions? We can take one more and then we can move on to the next section. Right. Emmy, can you see this question about the eligibility criteria that were included in the study? From
yes, I can see.
Mahindriran.
So the question is how many studies actually were excluded from the review, eh?
Yes, his question is there any estimate on the percentage of studies not qualify for the systematic review?
Yes, I will show you a flowchart in the next couple of slides where you can see how much studies we found and how much studies we excluded. So maybe I can come back with the numbers when I show you the slide. This will be better to explain. And it also shows you why we excluded some studies.
Wonderful.
Okay,
I think we can move on to the next section, Emmy.
Okay, perfect.
Thanks.
Now we come to the actual results of the review. As I told you before, we had two major research questions. First one was, what is the effectiveness of different approaches to promote hand washing and sanitation behavior change in communities in low and middle income countries compared to other approaches? So essentially this question is asking what works, what type of approaches work in a specific setting. And this type of questions is answered with quantitative studies. But I will come back to that in a minute. Second question was, what are the factors influencing implementation of approaches to promote hand washing and sanitation behavior change in communities in low and middle income countries? Question looking for under which circumstances and how and why are these programs working? And this type of questions is typically answered with research studies. So this is the flowchart where I was referring to. Here you can see how many studies and references we screened. So we looked for studies from 1980 to March 2016. And we identified 23,400 studies from scientific databases. In addition, we also checked a lot of other sources of information. And because a lot of information is unpublished, we also looked into different websites, different relevant websites, and we discussed it with our stakeholders, which were the relevant places to look for additional information. And there we checked more than 2,000 additional references of unpublished information. And with which I mean published in academic journals and in scientific databases. Together, we had more than 25,000 references that were screened for their title and abstract. So this was just based on the search terms we used to look into these different places. So just based on the title and the abstract of these references, we already excluded a lot of studies because they were not answering our questions of interest. But then, and this is the important step, and also the question the person was asking, because we had 522 references, which at first sight looked relevant to the question. So we checked the full text of these references, and we excluded 452 of these studies. So that is to answer your question, because these were not describing prevention of interest. It was not a promotion approach, for example, or it was not a population of interest. For example, it was not done in a low and middle income country, or it was in a hospital setting, for example, or it was not in a country or region of interest, or the outcome of interest was not mentioned. All the studies that only measured health outcomes, for example, were excluded because our primary outcome of interest was behavior change. And another very important aspect was the study type. If the study had not a controlled study, was not a controlled study, then it was excluded. Of course, for the qualitative studies, we had some other criteria. And in this way, we were able to identify 42 quantitative studies and 28 qualitative studies. I will now discuss the results of these studies. So first of all, research question 1. What is the effectiveness of different promotional approaches? What works? This question will be answered with the 42 quantitative studies. And a quantitative study measures quantitative data in an intervention and a control group. So it is a controlled study. First, I will show you some information on the characteristics of the 42 studies. So the majority of the studies were performed in Asia, 59% of the studies. And this was 25 studies were done in Asia. 13 studies were performed in Africa, and 4 in Central or South America. So the bubbles on the map show you the number of studies. So how bigger the bubble, how more studies were done in that country or region. So then, majority of the studies were performed in the community. Only a minority of studies was done in schools. 8 studies in schools, and only 1 study that was done both in the school and in the community. But 33 of the 42 studies were done in a community setting. Then we also checked for the setting, a rural setting or an urban setting or an informal rural setting, which is slums and settlements, or sometimes no information was provided on the setting. So most of the studies were performed in the rural setting, 29 studies, which is 69% of all the studies. And then we had 6 studies in an urban setting, 4 studies in a slums and settlement setting, and for some studies we don't have any additional information. Then the promotional approach, which is of course what we were interested in. Here we have the 4 categories that I already mentioned when I was explaining the theory of change: the community-based approaches, the social marketing approaches, the sanitation and hygiene messaging approaches, and the theory-based elements. So we found 13 studies for the community-based approaches, but in the table on the slide you can also see the WASH components. For example, there was in the community-based approaches only 1 study that targeted hand washing, but there were one intervention, not 1 study. Because sometimes in 1 study they had several intervention arms. Sometimes there was 1 group that was targeting hand washing and another group that was targeting sanitation. So, 15 arms that looked at sanitation and 2 that aimed at both hand washing and sanitation. And then 14 studies, combination of hand washing, water quality interventions, and sanitation interventions. And again, for social marketing, information is there on the slide. Again, some studies that only tested one WASH component, and some other studies tested some components at the same time. you see that for theory-based and social marketing, we only had 7 studies. So less information on this type of promotional approaches. The classification in these 4 groups, I said before, it was done according to the main promotional approach that was identified from the study. Because sometimes a social marketing approach also had some educational aspects in it or some community-based aspects in it, but based on the main promotional aspect, we categorized the studies in these 4 groups. And we did this with all our team members in parallel, because sometimes it was not always really clear. So we worked together with the methodological and the content experts of our panel to make this these 4 categories, and we also discussed it with our stakeholders. So then the outcomes of interest. So 21 studies measured hand washing at key times, and 12 studies hand washing with, in most cases, or without soap. 9 studies measured use and facial disposal practices. 8 studies measured open defecation, and 2 studies measured the intention to do something. As I mentioned before, we divided the actual behavior in 3 groups because we wanted to have a idea about longer-term outcomes. Used the wording uptake, adherence, and longer-term use. And uptake, this was really during the implementation, during a program. Adherence was 12 months after the program, after the implementation, and a longer-term use was more than 12 months after the end of the implementation ended. So you can see that 20 studies looking for short-term outcomes, and we only had 6 studies that measured longer-term outcomes, which was, of course, very important because the gap map already concluded that there was not a lot of information available on longer-term outcomes. Then we also had secondary outcomes. Primary outcomes were the behavior change outcomes that I showed you on this slide, and the secondary outcomes were the behavioral factors, knowledge, skills, attitude, self-regulation, norms, and the longer-term outcomes, morbidity and mortality at the other hand. And each time the number of studies that measured this outcome stated on the slide. We will not go into detail on the study quality. I want to show you that for each study we did a bias assessment, which means that we checked the limitations of study design, the studies we included. The red boxes mean that there is a high risk of bias for some elements of study quality. And this was taken into account when formulating the conclusions. So I will now come to the results of the review. We identified from the 42 quantitative studies, 33 studies that studied the effect of that actually compared a certain promotional approach control group that did not use the approach. Other studies compared approach A versus approach B, different promotional approaches. There was a high variability in promotional approaches, so it was not possible to statistically pool the results. So in a systematic review, if possible, the results are merged together in a pooled value, but this was not possible in this review. So therefore, we did a more narrative synthesis and analysis. We will provide you an overview of individual outcomes. Well, we made a synthesis of individual outcomes per promotional approach. We could not identify a promotional approach that was better than all other promotional approaches in achieving all outcomes. We found several promising promotional elements, and I will give you an overview on that. So this is the final synthesis. we try to create a visual scheme, giving you all the information in one overview. You see the 4 main categories and different outcomes of interest. But I will zoom in the different aspects of this graph. The different colors are different conclusions. We have the green and orange one boxes that mean that the intervention probably improves or reduces a certain outcome, or probably makes little or no difference. Probably is based on the quality that is behind it, because we can be quite sure, and it's reflected in the wording. On the other hand, we also have some conclusions where the word may in the wording. Light orange ones may improve or reduce outcomes. That ones may make little or no difference. This is based on low quality evidence. So here you see that the quality of the evidence is reflected in the final conclusion. We also have some gray boxes. The light gray ones mean that we are uncertain. A certain intervention improves or reduces a certain outcome because the quality is very low. And then the darker gray boxes mean that the conclusion is unclear or unknown. There's no evidence. We couldn't find any study, or only very limited evidence, for example, from only one study. So first of all, again, the community-based approaches. We had 12 studies that compared a community-based approach in the intervention group in the study to a group that did not use this community-based approach. 4 studies used CLTS, 2 used community-based interventions and clearly mentioned and described these as community-based interventions in their study protocol. 2 studies worked with community health clubs or groups, and 4 studies described clear elements of community involvement. This is the conclusion for the community-based approaches, where you can see that a community-based approach may improve handwashing on the short term and 12 months after the end of the intervention. So these are the boxes for handwashing, and may improve latrine use also longer term, more than 12 months after the end of the intervention. But we have evidence that is more certain for safe feces disposal practices and open defecation. So community-based approaches probably decrease open defecation practices until 12 months after the end of the intervention. This is the adherence box, and also may improve safe feces disposal practices until 12 months after the end of the intervention. So on a longer term, some evidence is lacking, as you can see that there are some gray boxes there. We had some other studies that compared 2 different approaches to each other. So there was one study comparing community health clubs versus a community-based total sanitation approach, but there no difference in latrine use and open feces disposal could be demonstrated. And then there was one study that studied the addition of incentives to community-based approaches, and the conclusion was that additional subsidies as incentive were linked with significantly bigger impacts on reducing open defecation. This is actually the only study in the whole review that tested the effect of incentives in this way. So for sure, there will be more evidence needed to make some conclusions about the usefulness of incentives. Then we have the social marketing approaches. We had 6 studies that compared a group using a social marketing approach to a control group not using this approach. 5 studies formally described that they used a marketing campaign or social marketing techniques or interventions. The study did not describe the approach as a formal marketing approach, but they used several elements that are generally part of a marketing approach, and that's why we also put it in the category of social marketing approach. The conclusions are shown here. So this is part of the graph I showed you. There we have some green boxes, meaning that a social marketing approach probably improves lead renews until 12 months after the program, and also decreases open defecation practices until 12 months after the program. This was about combined hand washing and sanitation interventions. For all the other aspects, on hand washing, for example, we are uncertain. The effect is unknown because there was not a lot of evidence available. And also, as you can see, on the longer term, so more than 12 months after the end of the program, there is no evidence available. There was also another study that compared two different social marketing approaches with each other. This one was called the local builder social marketing approach, which means that they worked with constructors from within the community, versus an approach where an outside expert building team was involved. And the conclusion was that a local builder social marketing approach had a significant decrease in the number of households that refused to use a new toilet. So that local builders was a positive aspect. Then we have the group of sanitation and hygiene messaging. We had 12 studies there that compared this type of approach to a group not using this approach. We had 4 studies with school-based interventions, and then 8 studies with a teaching component targeted at the community. And I provided some examples there to make it clear. This could be an instructional lesson, a video in the waiting room of a health center, for example, just a movie, flyers or pamphlets, a slideshow, or just ask people to memorize messages. Or really a directive approach. So here you can see that such type of approach probably improves hand washing at the short term, but it would make little or no difference at longer term, more than 12 months after the end of the program, and even on a longer term, this type of approach may make little or no difference. So these are the orange and the red boxes with hand washing. No information or almost no information was available on lead renews, so we can't make any conclusions on this type of outcome. And then again, for safe feces disposal practices and for open defecation, we see some red boxes, meaning that this type of messaging may make little or no difference to safe feces disposal practices or open defecation practices. And on a longer term, more than 12 months after the end of the program, the effect is unknown because there is no evidence available. So we had one study that compared two types of approaches, two types of educational approaches with each other. We had education with a poster contest, education without this poster contest. So this was one element that was added to the approach to check the effect of the addition. And a significant increase in hand washing was demonstrated when this poster content was added to the educational approach, which shows that some interactive components in such a approach are very important. Then the fourth category was using elements of psychosocial theory. We had 4 studies there that described the theory of planned behavior, the TANAS model, the Super approach, and the different stages of change theory. And these are the conclusions. So 4 studies is not a lot of evidence. For hand washing, there was evidence concluding that these theory-based elements may improve hand washing term and probably improves hand washing on a longer term. But even on a longer term, more than 12 months after the end of the intervention, no evidence was available. And for the sanitation aspects, no evidence was available as well. So we also had some studies that compared different approaches. First, we had a group of studies that compared educational approaches where theory-based elements were added to. Two studies that elements of infrastructure promotion in their educational approach, and this resulted in a significantly improved hand washing. Study checked addition of elements of public commitment, but there no effect on hand washing was shown, and some effect on behavioral factors were shown. And a combination was made. So elements of infrastructure promotion and public commitment were added in the approach. There was, again, an improved hand washing. And then when elements of disgust were added to an existing educational approach, there was an improvement in hand washing and hand washing knowledge, but the effect on the feeling of disgust could not be shown. Then a study that tried different combinations of theory-based elements. So there was an approach where motivational intervention was followed by self-regulatory intervention. Then in the other study arm, they did the same approach, but in a different order. So they first started with self-regulatory intervention components, followed by motivational intervention components. But no difference was demonstrated in this study. On top of the four promotional categories that I just described, we also had some studies that mainly tested different ways of communication within one type of approach. So we listed the types of communication that can be used with a promotional approach. And we have listed interpersonal communication, which is doing home visits or focus groups, working with WASH committees or village health workers. But then you have a mass media way of communication, which is making use of a poster or a radio spot, newspapers. And then traditional communication, which we defined as using songs or drama or cinema, for example. We had two studies that tested the way of communication. In a first study, media approach, where interpersonal communication was stressed. And this was compared to the use of mass media alone. And it was shown that there was a significant increase in hand washing and a decrease in morbidity outcomes when interpersonal communication was added to mass media approach. So showing you that personal communication is very important. And then we had a study that looked at mass media and direct consumer contact versus not using an approach. And there, no effect on behavior or behavioral factors could be demonstrated. While a combination with community involvement on hand washing and knowledge. So community involvement was very important here. To the overall conclusion, working in a community-based way and involving the community probably improves sanitation behaviors, open defecation, latrine use, and may improve hand washing. There were limited positive results on the knowledge of key hand washing times, and it was less clear at the longer term. For social marketing, it probably decreases open defecation free, improves latrine use behavior up until 12 months following the implementation, and effects on hand washing are unclear. Sanitation and hygiene messaging, there was mainly a short-term effect on hand washing. No effects seen on sanitation. For elements of psychosocial theory, we saw that this was very promising in terms of hand washing. It certainly warrants further research. Impact on sanitation is currently unknown. Then we also found that the use of interpersonal communication and using interactive educational elements were shown to be effective in certain circumstances. Okay, next research question was about factors influencing implementation of promotional approaches. And this is the type of question that is being answered with qualitative studies. Identified 28 qualitative studies, and a qualitative study uses interviews, focus group discussions to obtain descriptive information, no data or no numeric numbers. This is again the world map with showing you where the studies were performed. Were a lot of African countries this time. And then the setting and the target level was it was a little bit the same as for the quantitative studies. So most of the studies were done in a rural setting, and most of the studies targeted the community. So here you can see the WASH components and the promotional approaches in the studies. As you can see, there was a lot of information from qualitative studies on community-based approaches and less information on social marketing, messaging, and on theory-based elements. Some studies targeted hand washing or sanitation, but 14 studies combined all these aspects together. Study quality, we also took this into account. I'm not going into detail here. We use the validated checklist to think about the quality of these qualitative studies. This is the theory of change again, and all the blue boxes you see on this theory of change were filled with information based on qualitative studies. So I will zoom in on some of these just as an example, so you have an idea of the information that you can get from qualitative studies. So this is the box with program environment factors. These are factors that are related to the program. For example, training of the implementer, the training materials, and some other points. I will zoom in on these, and here you can see all these, for example, training materials, connections to the community, qualification of the implementers. And from the qualitative studies, we looked for barriers and enablers of all these factors. So here you can see a list of barriers that we identified from our studies and a list of enablers. And just even zoom in more detail, if we take one of these factors, partnership, coordination between providers of the same intervention or other health interventions, barriers thereof, we see that partnership between members was cited in some studies, lack of partnership with the private sector, lack of information, lack of responsibility. Each of these elements is backed up with quotes and statements from the qualitative studies. This is all available in the review. The quotes and the statements from qualitative research support all these factors, all these barriers, can be found in the full review. Same with another box here, the process evaluation factors. So as I told you before, these measures of program implementation. And some examples of these factors are acceptability, adaptation, DOS, engagement, and so on. We identified barriers and enablers of all these factors. And again, we can zoom in on some of them. Engagement is one of the important factors. And there we found some enablers: enthusiasm, income-generating activities, leadership. And for all these aspects, we have some quotes to back this up. So this is the qualitative evidence that we identified. So it would take us very far to go into detail. And these are the last couple of slides on the results of the review. I made a list of enablers, found that to be relevant across all the promotional approaches, and then I have barriers and enablers for each of the approaches. So for all the approaches, we found that longer intervention periods with adequate follow-up was very important. The implementer, using short communication messages, having training materials, of course, financial assistance, partnerships, kindness and respect of the implementer, accessibility of the implementer, and the state authority of the implementer. Community-based approaches, I will just pick a few of the enablers. The enthusiasm of the community leaders, sex of the implementer being suited to the community member was found to be very important from several qualitative studies. Trust between the community and the implementer, to be able to form identity within a health club by using a slogan, for example, a logo, was very important for people. Barriers were lack of communication, mentioned several times, and lack of training. For social marketing approaches, working with local contractors was found to be an enabler and taking into account consumer preferences. And then some barriers were identified, and most of the barriers were dealing with financial issues. Sanitation loans not reaching poor people, sanitation loan officers' attitudes, a high interest rate on loans, long processing times to obtain the loan, lack of financial knowledge, and poverty. And then sanitation and hygiene messaging, some enablers, interactive teaching, teaching methods, innovative messaging, barriers, passive teaching methods, the need for longer intervention periods, overlap between school interventions and community-based interventions, illiteracy was also a barrier. So our message is there is not one promotional approach that is most effective, but several promising promotional elements were identified and several barriers and enablers influencing implementation were identified. This was a very big section, of course, with all the results of the review, and I propose that we have some questions now.
Thank you, Emmy. We already have a question coming up from John. So, John, could I request you to please ask your question?
Here we go. Hello. Can you hear me?
We can.
Yes.
Loud and clear. Thank you.
Okay, great. So, yeah, thank you very much. That was a great presentation, very detailed. So I'll make a bit of a comment. I've been working in this field for a long, long time. And there's two things I've learned over the many years. One thing is very difficult to measure hand washing, as you've learned yourself. And all those studies, they probably have different ways of measuring it. So it is very difficult to determine what's most effective. And the other thing is, especially in rural areas, it's actually very difficult to change this behaviour. So I think our ambition level has always been a little bit too high, if you think of the effort that goes into trying to change behaviours. So I wanted just to talk a little bit about the combination of approaches, because I did start out a long time ago doing research on sort of social marketing. And I've been moving more to in different countries, looking at CLTS as an approach, and I think that some of this combination would be useful to tease out. I know you've categorized the different types of approaches, but they do complement some of these. And I'd say that for CLTS, the ODF sort of verification is also quite strong if we're looking at trying to have sustainability, because usually hand washing is part of that ODF verification. The danger there is that sometimes it's a little bit of a light touch on the hand washing and more emphasis on the toilets. So I think it's a matter of making sure the approach looks at emphasizing hand washing more, because it's easy to sort of disregard the hand washing part of it and just focus more on the toilet side. But if that sort of approach could be combined with the marketing, because there you're using discuss. So when you're looking at those the theory-based approaches, which do come from marketing as well, I think there's opportunities there for combining the two, and I've seen that work quite well in some countries. And finally, I just mentioned a little bit on schools. I know you touched on schools, and again, I think that's also something that can complement other approaches. I don't think it's a standalone, but again, I think where they've been trying to get group hand washing together, it's something that you can do quite easily with the teachers to try and get the pupils to form the habit early on, and then bring that home to the households. I think as well is good to complement other type of approaches. But it's more like a comment, I'm afraid. So it's not really a question, because I know it's difficult to use all that evidence to say now what will the combined approach be like.
Yes, and probably the main conclusion is that these combination of approaches or promotional elements, to make this combination for each context and for, yes, each, yeah, all over again. It's not if a certain combination works that it will work in another context, of course. But very, very useful comments, and I think maybe others can comment on this as well from their practice experience in the field.
Thank you. Thank you, Emmy. Thank you, John. We have two more questions, but I was wondering, Susan's question is about the application of this study knowledge at the practitioner's field, as in to have standard definitions of different indicators. And I'm wondering, Emmy, perhaps we could take it after your final section, where you talk about the application of the knowledge at the practitioners and researchers level. And I'm looking at Lena's question now. Lena, would you be so kind to just repeat your question to Emmy?
Hello, can you hear me?
We can.
Yes, I can hear you.
Wonderful. For your amazing presentation. I wanted actually to find out a little bit more about the sanitation component of the behavior change literature that you were reading. If you came across for the safe feces disposal interventions, whether it went beyond containment. So looking across the sanitation chain, in other words, the hand washing and sanitation, it looked beyond targeting users. So for example,
sorry, Lena, I didn't hear the last part of your question. But first part was
yes,
asking about.
I don't know my.
Emmy, Lena's question is also on the screen.
Yes, I'm just checking it right now because yes, I only heard part of her question. So first part of the question was asking to clarify if safe feces disposal interventions went beyond containment by looking at emptying, transport, and so on. This is a difficult thing with the studies. In most cases, they measure a lot of outcomes at the same time, and in most of the times they just don't provide any definitions for what they call safe feces disposal. So and then we just take over their wording. We just also use feces disposal, but as far as I know, no additional information on looking at emptying and all the other aspects were not provided. And this is a very difficult thing. It was also mentioned by the previous person who had a comment, because all these outcomes are measured in different ways in all the studies. And it's a major conclusion, because for the future and for future research, there should be a more uniform way of these outcomes. It's also based on what is useful for practice. And this makes it very difficult to make overall conclusions. Second part of your question was about if the review went beyond targeting users. Yes, I'm not really sure if I understand correctly what you mean there.
What I mean is that literature I've reviewed, in general, it tends to be, let's say, the person that we want to wash hands, or the person that we want to can help them in multiple levels in terms of governance, whether you're talking about your service providers or other people that are involved in agents. The literature that you came across did actually go beyond what you referred to as, let's say, the community or students in schools.
No, in the studies we included, this was yes, the group that was targeted was the community or schools, and yes, that was the target level
Is
of
this
the
because of your
studies
targeting,
included.
though? Is this because of your targeting for the systematic review, or did you not the literature that you reviewed, and these were who they targeted?
In our criteria, we said that we would include studies that targeted the community and schools. So probably studies that targeted other groups excluded, but studies describing both should be in the review. But in the studies included in our review,
okay.
this information was not available.
Okay, thank you for clarifying.
Emmy, hi.
Yes.
We've got a couple of more questions, but I am conscious about the time. So we would respond to those questions, as I said in the beginning, that we will consolidate some of the responses and we will send it out to all.
Yes, of course.
But considering the time constraints, let's move on to the final leg of the presentation, please.
Okay, I only have 2 or 3 more slides, so we are almost there. So what does it mean for practice? We discussed all our results with a broader stakeholder group, also including donors and policymakers and experts, field experts as well. And we worked with them again on the theory of change. So all the results of our review were coupled back to the theory of change. We mainly discussed with them the implications of our results for practice and research. So my next 2 slides summarize the consequences and implications for policy and practice, and also for research. So first of all, promotional approaches at hand washing and sanitation behavior change can be effective in terms of hand washing with soap, veteran use, safe fishes disposal, and open defecation. It was shown by all the studies we identified. And a combination of different approaches, of different promotional elements, we call it, is probably the most effective strategy. Then, of course, the recognition of different barriers and facilitators or enablers that influence the implementation of these approaches may have a triggering effect on its effectiveness. So it would be very important to take these barriers and enablers into account and to test the different barriers and enablers for different approaches. There is currently not enough evidence to answer major policy questions around the incorporation of financing into sanitation promotion approaches. There was currently only 1 study that checked the effect of incentives and financial incentives, so more research would be welcome on that. So this leads us to implications for research. So as we already said, an important implication is that there is an urgent need to use more uniform methods of outcome measurement. And I mean the type of outcomes, but also the way of assessment, because all these outcomes are measured in different ways. Timing of assessment, if there would be a more uniform method there, this would improve research and reviews, future reviews a lot. Facilitate making conclusions on the effects of promotional approaches in the future. And of course, it is important to further assess barriers and facilitators identified in this review, alongside quantitative analysis of promotional approaches. So this is the take-home message combination of different promotional elements, probably the most effective strategy, bearing in mind the context and profile of the target community, and formative research to assess the context and the situation will help to determine which influencing factors to take into account and which elements to include in a promotional strategy. And I will already go to this slide, because here you can find all the resources on this review. We have some resources on the CEBaP website and some on the Campbell Library. The ones with the red arrows are a systematic review summary and which is a very condensed summary of the review. An even more condensed version of that is the systematic review brief. It's only 2 pages, and it's also with a lot of graphics in it. So this can be very useful if you would like to have a summarized overview of the conclusions of the review. But also the full review can be downloaded, but it's more than 400 pages long. So check out and download the resources, and of course discuss what the findings mean for your daily practice. Vitali, we have a couple of minutes left, so up to you.
Indeed, indeed. Wonderful. Thanks a lot, Emmy. That was a very comprehensive take on the systematic review. I do have a couple of questions waiting in there. Suzanne's question has been partially responded. She has come back with another question where she's asking you, do you have recommendations for the common indicators to use?
We are actually working on a paper. So, yes, it will be very difficult. We will be doing an impact evaluation ourselves in the future, and we would like to publish a research paper with some recommendations on common indicators. But I'm afraid I will not be able to answer this question right now, because we are still thinking about this, because it's a very complex situation, of course, but this would be good for the future.
Wonderful, thank you. I'm just sifting through these. Okay, Safianu Bishi from Nigeria. Safianu, can you hear me? Safianu, your question on institutional capacity. Okay, I'm going to move on to another question. Valerie, could you just, scroll up. Okay, now, hang on. Yvonne from Mozambique. Yvonne from Mozambique. Emmy, you can actually read the question that Yvonne has posed.
I have the question here. It's about in schools. How to make a school buy in the approach so that they keep on spreading the habit. I think a lot of the barriers and enablers will be very relevant. So I think it would be very interesting to go through the list of barriers and enablers and to try to incorporate this in your program. We have some that were specifically dedicated to the messaging approaches, which is more related to the school-based interventions. So that would be one suggestion. And, the other thing is that based on also the quantitative results we had, that it seemed that adding interactive elements are all important aspects. No plenary talks, but just add on some interactive elements, and it will help you in implement on the longer term, according to the information in the studies.
Wonderful. I think with that we have almost come towards an end to this webinar. I just want to say a huge thank you again, Emmy, for that wonderful presentation, very comprehensive, extremely clear, and also some of the thought-provoking takeaway messages. So thank you once again from our end. Also a huge thank you to all the participants for listening to the webinar. We encourage you all to send your questions, and I apologize that we didn't have enough time, but we will try and respond to 10 to 15 thematic questions in next couple of weeks' time. Emmy and her team has been very kind to offer that technical help to us. We will also make the presentation, as some of you have already requested, the presentation available to you. As you all know, we do have a community of practice that's hosted and moderated by WSSCC. So hopefully you will continue the conversation and the discussion on the co-op and join the co-op if you're not a member of co-op yet. And we will at some point in time see if we can have a moderated discussion in co-op also. We are trying to see what's the possibility of doing that. So I'm looking at Valerie. Have I covered all the points?
Yes, and all the questions, if they have any more further questions, they can send them to me, and I'll put them together, and then we'll respond on the call.
Perfect. So that was clear. Valerie is typing her email ID. So please do send your questions. And thank you once again to all of you. Thanks to the colleagues also here who have attended the webinar from WSSCC. Thanks a lot.
Thank you. Bye.
Thanks. Bye.